Question 1. A patient is admitted to the hospital with acute abdominal pain. After a thorough workup, the final diagnosis is acute appendicitis without perforation or gangrene. What is the principal diagnosis? I. R10 is 0, acute abdomen. B. K35-80, acute appendicitis unspecified. C. R10-9, unspecified abdominal pain. D. K35-890, other acute appendicitis without perforation or gangrene. Answer D. K35-890, other acute appendicitis without perforation or gangrene. This question tests the concept of sequencing the principal diagnosis based on the definitive diagnosis. The keywords final diagnosis and acute appendicitis without perforation or gangrene clearly indicate that the initial symptom, abdominal pain, is no longer the focus once a definitive condition is identified. In ICD-10-CM, when a definitive diagnosis is established, it supersedes codes for symptoms or signs. For instance, if a patient initially complains of chest pain R079 but is later diagnosed with an acute myocardial infarction I21X, the myocardial infarction becomes the principal diagnosis. Always code to the highest level of specificity and use the definitive diagnosis when available, as symptoms are only coded when no definitive diagnosis has been made. Question 2. A patient presents with acute osteomyelitis of the left femur. How would this condition be coded in ICD-10-CM? I. M86-151. B. M86-152. C. M86-159. D. M86-10. Answer B. M86-152. This question tests your knowledge of laterality coding within ICD-10-CM. The keyword left femur is crucial for selecting the correct code. Many ICD-10-CM codes specify laterality to indicate whether the condition affects the right side, left side, or is bilateral. Code M86-152 specifically identifies acute osteomyelitis of the left femur, while M86-151 is for the right femur, and M86-159 is for an unspecified femur. For example, if documentation states right elbow fracture, you must select the code indicating the right side, not left or unspecified. Remember to always check for laterality in the ICD-10-CM index and tabular list to ensure the most specific and accurate code selection. Question 3. A patient has a history of breast cancer, successfully removed 5 years ago, and is now diagnosed with metastatic carcinoma to the lumbar spine. Which code should be sequenced first for the current encounter? I. C79-51, secondary malignant neoplasm of bone, lumbar spine. B. Z85-3, personal history of malignant neoplasm of breast. C. C50-919, malignant neoplasm of unspecified part of unspecified female breast. D. C79-52, secondary malignant neoplasm of bone, sacral and coccygeal. Answer I. C79-51, secondary malignant neoplasm of bone, lumbar spine. This question tests the coding guidelines for neoplasms, specifically when a patient presents for treatment of metastatic disease. The keywords now diagnosed with metastatic carcinoma to the lumbar spine and history of breast cancer, successfully removed D, indicate that the current encounter focuses on the secondary malignancy. When an encounter is for the treatment of a secondary malignancy and the primary site is no longer active or unknown, the secondary malignancy code is sequenced as the principal diagnosis. For instance, if a patient is admitted solely for treating liver metastases from an unknown primary, the code for the secondary liver cancer would be primary. Always prioritize the condition currently being treated, even if it's a spread from a prior, resolved cancer. Question 4. A patient with type 2 diabetes presents with diabetic polyneuropathy. How should this condition be coded? I. G63, polyneuropathy in diseases classified elsewhere. B. E1140, type 2 diabetes mellitus with diabetic neuropathy, unspecified. C. E1142, type 2 diabetes mellitus with diabetic polyneuropathy. D. E11-9, type 2 diabetes mellitus without complications. Answer C. E1142, type 2 diabetes mellitus with diabetic polyneuropathy. This question assesses your ability to use combination codes in ICD-10-CM, especially for diabetes and its complications. The keywords type 2 diabetes and diabetic polyneuropathy are essential because ICD-10-CM presumes a causal relationship between diabetes and many associated conditions, such as neuropathy, unless the physician explicitly states they are unrelated. Therefore, a single combination code that captures both conditions is generally appropriate and preferred over coding each condition separately. For example, instead of coding E11-9 and G63, which would incorrectly imply the polyneuropathy is not diabetic, the combination code E1142 accurately reflects the diabetic nature of the polyneuropathy. Remember to always look for specific combination codes that completely describe the documented condition, linking the underlying disease with its manifestation. Question 5. A patient tests positive for HIV, but is asymptomatic and does not have any related conditions. How should this be coded? I. B20 human immunodeficiency virus, HIV disease. B. R75 inconclusive laboratory evidence of HIV. C. Z21 asymptomatic human immunodeficiency virus, HIV infection status. D. Z11 for encounter for screening for human immunodeficiency virus, HIV. Answer C. Z21 asymptomatic human immunodeficiency virus, HIV infection status. This question specifically tests the ICD-10-CM guideline for coding asymptomatic HIV infection. The keywords tests positive for HIV, asymptomatic, and does not have any related conditions are critical. According to coding guidelines, if a patient is confirmed HIV positive but has not developed any symptoms or manifestations of HIV disease, code Z21 is used. Code B20 is reserved for symptomatic HIV disease, while R75 is for inconclusive test results and Z11-4 is for screening, not a confirmed positive status. For example, if a patient with no current HIV-related symptoms tests positive during a routine blood test, Z21 accurately describes their status. Always ensure you differentiate between asymptomatic HIV infection and active HIV disease, as separate codes exist for each. Question 6. A patient is admitted for severe nausea and vomiting due to an adverse effect of a prescribed dosage of her hypertension medication, lisinopril. How should this be coded? I. T46 4X5A adverse effect of ACE inhibitors, initial encounter. B. T46 4X1A poisoning by ACE inhibitors, accidental, unintentional, initial encounter. C. R11-2 nausea with vomiting, unspecified. D. R11-10 vomiting, unspecified. Answer I. T46 4X5A adverse effect of ACE inhibitors, initial encounter. This question tests the distinction between an adverse effect and a poisoning in ICD-10. The crucial keywords are adverse effect, prescribed dosage, and hypertension medication lisinopril, which is an ACE inhibitor. An adverse effect occurs when a drug is correctly prescribed and properly administered but causes an undesirable reaction. Poisoning, conversely, involves an overdose, wrong substance, or medication error. In this scenario, since the medication was taken as prescribed, the reaction is classified as an adverse effect. For example, if a patient experiences stomach upset from a correctly taken antibiotic, it's an adverse effect. Always clarify whether the medication was administered correctly to distinguish between an adverse effect and a poisoning. Question 7. A patient fell at home and sustained a closed fracture of the right tibia. This is their first visit for this injury. Which code category would indicate the initial encounter? I. S82-201A. B. S82-201D. C. S82-201S. D. M84 451A. Answer I. S82-201A. This question assesses your understanding of the 7th character for injury codes in ICD-10-CM. The keywords "first visit" for this injury explicitly point to an initial encounter. For most injury and external cause codes, a 7th character is required to specify the type of encounter. A for initial, D for subsequent, and S for sequela. Code S82-201A correctly identifies a closed fracture of the right tibia during the initial encounter, meaning the patient is receiving active treatment for the injury. For example, if a patient is seen for the first time for a broken arm, the 7th character would be appended to the fracture code. Always pay close attention to the encounter type to select the appropriate 7th character for injury and poisoning codes. Question 8. A patient is seen for treatment of a hypertrophic scar resulting from a severe burn 2 years ago. What is the appropriate code for the hypertrophic scar as the primary reason for the encounter? I. T2239XA, burn of 3rd degree of unspecified part of upper limb, initial encounter. B. L95, scar conditions and fibrosis of skin. C. T2239XS, burn of 3rd degree of unspecified part of upper limb, sequela. D. L91-0, hypertrophic scar. Answer D. L91-0, hypertrophic scar. This question tests the coding of sequelae, specifically when the residual condition is the primary focus of the encounter. The keywords hypertrophic scar and resulting from a severe burn 2 years ago indicate that the current condition being treated is the scar, which is a sequela of the burn. While a burn code with a 7th character S, T2239XS, would be reported secondarily to identify the cause of the sequela, the specific code for the hypertrophic scar itself, L91-0, is the most appropriate principal diagnosis for the current treatment. For instance, if a patient is undergoing therapy for paralysis resulting from a stroke, the paralysis G83X is coded first, followed by the stroke code I69X with an 7th character. Always code the current residual condition first when it is the primary reason for the visit, and then add the sequela code for the original cause. Question 9. A patient is diagnosed with both chronic kidney disease, CKD, and hypertension. The physician documents hypertensive kidney disease. How should this be coded? I12-9, hypertensive chronic kidney disease with stage 1 through stage 4 chronic kidney disease or unspecified chronic kidney disease. B. I10, essential primary hypertension. C. N18-9, chronic kidney disease unspecified. D. I12-0, hypertensive chronic kidney disease with stage 5 chronic kidney disease or end-stage renal disease. Answer I. I12-9, hypertensive chronic kidney disease with stage 1 through stage 4 chronic kidney disease or unspecified chronic kidney disease. This question focuses on the with guideline in ICD-10-CM, which implies a causal relationship between two conditions documented together. The crucial keyword, hypertensive kidney disease, explicitly links hypertension and chronic kidney disease, meaning a combination code should be used. Unless the provider specifically states that the two conditions are unrelated, the guideline instructs to assume a direct link. Since no specific stage of CKD is documented, the unspecified stage, I12-9, is appropriate. For example, if diabetic retinopathy is documented, a combination code linking diabetes and retinopathy is used, rather than separate codes for each. Always use a combination code when two conditions are linked by the physician's documentation or by the with guideline if one exists. Question 10. A patient comes in for a routine checkup. The physician notes a history of colon cancer, which was successfully treated 5 years ago and shows no recurrence. What is the appropriate code for the history of cancer? I. C18-9, malignant neoplasm of colon unspecified. B. Z85-038, personal history of other malignant neoplasm of large intestine. C. Z08, encounter for follow-up examination after completed treatment for malignant neoplasm. D. Z80-0. Family history of malignant neoplasm of digestive organs. Answer B. Z85-038. Personal history of other malignant neoplasm of large intestine. This question tests the use of personal history codes in ICD-10-CM. The keywords history of colon cancer, successfully treated 5 years ago, and shows no recurrence indicate that the patient no longer has the active disease. Personal history codes, Z85 series, are used when a patient previously had a condition that has been resolved and no longer exists, but which may have an impact on current care or require monitoring. Code C18-9 would be for an active malignancy, and Z08 is for active follow-up after treatment, but while still considered under surveillance for recurrence, which is different from a resolved past condition. For example, a patient with a removed appendix has a personal history of appendicitis. Always use a personal history code when a condition is completely resolved and not currently being treated or monitored for recurrence. Question 11. A patient presents to the emergency department after a motor vehicle accident, complaining of headache and dizziness. After examination, no injuries are found, and the patient is discharged home with instructions to return if symptoms worsen. The patient was observed for a potential head injury. How should this be coded? I. G44-8 Other specified headache syndromes. B. R51 Headache. C. Z043 Encounter for examination and observation following other accident. D. R42 Dizziness and giddiness. Answer C. Z043 Encounter for examination and observation following other accident. This question assesses the use of Z codes for observation, particularly when a suspected condition is ruled out. The keywords no injuries are found, discharged home, and observed for potential head injury are crucial. When a patient is admitted for observation for a suspected condition that is subsequently ruled out, the appropriate Z code for observation is sequenced as the principal diagnosis. Symptom codes, like R51 for headache or R42 for dizziness, are not used as principal diagnoses in this scenario because the primary reason for the encounter was the observation following the accident, which led to ruling out an injury. For instance, a child admitted for observation due to suspected ingestion of a foreign object, which is then cleared, would be coded with an observation Z code. Always use an observation Z code when the purpose of the encounter is observation for a suspected condition that is ultimately ruled out. Question 12. A patient develops an infection at the surgical incision site following an appendectomy. The patient is readmitted for treatment of the infection. How should the infection be coded as the principal diagnosis for the readmission? I. K38-8 Other specified diseases of appendix. B. T81-4XXA Infection following a procedure, initial encounter. C. Z98-89 Other post-procedural states. D. L03-116 Cellulitis of abdominal wall. Answer B. T81-4XXA Infection following a procedure, initial encounter. This question tests the coding of post-procedural complications as the principal diagnosis. The keywords infection at the surgical incision site and following an appendectomy clearly indicate a complication directly related to a surgical procedure. In such cases, the complication code from Chapter 19 T codes is assigned as the principal diagnosis, as it represents the reason for the readmission. A more specific code describing the type of infection, such as L03-116 for cellulitis, would then be reported as a secondary diagnosis. For example, if a patient is readmitted for a postoperative hemorrhage, the T code for hemorrhage following a procedure would be principal. Always prioritize the complication code when a patient is admitted primarily for treatment of a post-procedural issue. Question 13. A patient is diagnosed with pneumonia. No further documentation regarding the type or causative organism is available. What is the most appropriate code? I. J18-9 Pneumonia, unspecified organism. B. J12-9 Viral pneumonia, unspecified. C. J13 Pneumonia due to Streptococcus pneumoniae. D. J15-9 Bacterial pneumonia, unspecified. Answer I. J18-9. Pneumonia, unspecified organism. This question evaluates your understanding of coding to the highest level of specificity based on available documentation. The keyword unspecified and the statement no further documentation regarding the type or causative organism are critical. In ICD-10-CM, if the physician documents a diagnosis like pneumonia without further detail on the specific type or infectious agent, you must select the appropriate unspecified code. It is inappropriate to assume a specific type, e.g., viral or bacterial, or organism if not documented. For instance, if documentation states gastritis without specifying acute or chronic, you would code unspecified gastritis. Always code only what is clearly documented, using unspecified codes when detailed information is lacking. Question 14. A patient sustained a laceration to the arm after being attacked by a dog in a public park. Which external cause code category should be used to describe the place of occurrence? I. W54 0. Bitten by dog. B. Y04XXXA. Assault by bodily force, initial encounter. C. Y92 830 public park. D. X99 1. Assault by sharp object. Answer C. Y92 830 public park. This question specifically tests your knowledge of external cause codes, particularly for the place of occurrence category. The keywords public park and the explicit request for place of occurrence guide you to the correct code. External cause codes provide supplementary information about how an injury occurred, the intent, the place it occurred, the activity the patient was engaged in, and their status. While W54-0 describes the cause, dog bite, Y92-830 describes where the incident took place. For example, if someone falls in a grocery store, you would use a code from the Y92 category to specify supermarket. Remember to use separate external cause codes for each piece of information, cause, intent, place, activity, status, when available, rather than trying to combine them into one. Question 15. A patient has both acute and chronic sinusitis of the maxillary sinus. The physician documents both as present. How should this be coded? I. J0100. Acute maxillary sinusitis, unspecified. B. J32-0. Chronic maxillary sinusitis. C. Both J0100 and J32-0 should be reported. D. Only J32-0 should be reported, as it is chronic. Answer C. Both J0100 and J32-0 should be reported. This question tests the ICD-10-CM guideline for coding both acute and chronic conditions. The crucial keywords are both acute and chronic sinusitis and physician documents both as present. When the same condition is documented as both acute and chronic, and separate codes exist for each, both codes should be reported. The acute code is sequenced first, followed by the chronic code. It is incorrect to simply choose one over the other if both are clearly present. For example, if a patient has both acute and chronic bronchitis, you would code both the acute bronchitis, J20X, and the chronic bronchitis, J42. Always code both conditions when they are concurrently present and documented by the physician. Question 16. A patient is admitted for chemotherapy for breast cancer. She is also found to have anemia due to the chemotherapy. How should this be coded? I. C5919. Malignant neoplasm of unspecified part of unspecified female breast, D6481, anemia due to antineoplastic chemotherapy, Z5111, encounter for antineoplastic chemotherapy. B. Z5111, encounter for antineoplastic chemotherapy, C5919, malignant neoplasm of unspecified part of unspecified female breast, D6481, anemia due to antineoplastic chemotherapy. C. D6481, anemia due to antineoplastic chemotherapy, C5919, malignant neoplasm of unspecified part of unspecified female breast, Z5111, encounter for antineoplastic chemotherapy. D. C5919, malignant neoplasm of unspecified part of unspecified female breast. Z5111, encounter for antineoplastic chemotherapy. Answer B. Z5111, encounter for antineoplastic chemotherapy. C5919, malignant neoplasm of unspecified part of unspecified female breast. D6481, anemia due to antineoplastic chemotherapy. This question tests the sequencing guidelines for chemotherapy encounters and complications. The keyword admitted for chemotherapy indicates that the primary reason for the encounter is the antineoplastic treatment. Therefore, the Z code for chemotherapy, Z5111, is sequenced as the principal diagnosis. The malignancy, C5919, is then coded as a secondary diagnosis, followed by the complication of the chemotherapy, which is anemia due to antineoplastic chemotherapy, D6481. This sequencing ensures the encounter's main purpose is correctly identified. For example, if a patient receives radiation therapy for prostate cancer and develops radiation sickness, Z5110 radiation therapy would be primary, then the cancer, then the radiation sickness. Remember, the primary focus of the encounter dictates the principal diagnosis. Question 17. A patient has hypertension and atherosclerotic heart disease. The physician documentation specifies hypertensive heart disease with heart failure. How should this be coded? I-10 essential, primary hypertension, I-25-10, atherosclerotic heart disease of native coronary artery without angina pectoris. B. I-59 heart failure unspecified, I-10 essential, primary hypertension. C. I-11-0 hypertensive heart disease with heart failure. D. I-11-9 hypertensive heart disease without heart failure. Answer C. I-11-0 hypertensive heart disease with heart failure. This question focuses on the specific ICD-10-CM combination codes for hypertension and heart conditions. The crucial keywords, hypertensive heart disease with heart failure, explicitly link the hypertension to the heart condition, necessitating a combination code. ICD-10-CM provides specific codes that capture the combined diagnosis of hypertension affecting the heart, especially when heart failure is also present. It's important not to code hypertension, I-10, and heart disease, I-50X or I-25X, separately when a combination code exists that fully describes the relationship. For example, if a patient has hypertensive kidney disease, you would use a single code from the I-12 series, not I-10 and N-18X separately. Always look for and utilize available combination codes that describe the interconnectedness of conditions like hypertension and its manifestations. Question 18. A 2-day-old newborn is diagnosed with neonatal jaundice. How should this be coded? I. P59-9, neonatal jaundice, unspecified. B. R17, unspecified jaundice. C. K76-8, other specified diseases of liver. D. Z3800, live-born infant, born in hospital, unspecified as to type of birth. Answer I. P59-9, neonatal jaundice, unspecified. This question tests your knowledge of codes from Chapter 16, codes for conditions originating in the perinatal period, P00, P96. The keywords 2-day-old newborn and neonatal jaundice are critical because conditions specific to the perinatal period must be coded using P codes. These codes are exclusively for use on the maternal record or the newborn record, depending on the situation, and take precedence over equivalent R codes, symptoms/signs, or K codes, diseases of the digestive system, when describing conditions in newborns. For instance, respiratory distress in a newborn would use a P code, e.g., P220, not an R code for respiratory symptoms in an adult. Always use P codes for conditions originating in the perinatal period when coding for newborns, as they provide specificity relevant to this age group. Question 19. A 30-week pregnant patient is diagnosed with gestational diabetes, controlled by diet. How should this be coded? I. O24-410, gestational diabetes mellitus, unspecified in pregnancy, controlled by diet. B. 024-419, gestational diabetes mellitus, unspecified in pregnancy, unspecified control. C. E11-9, type 2 diabetes mellitus without complications. D. 024-919, unspecified diabetes mellitus in pregnancy, unspecified control. Answer I. 024-410, gestational diabetes mellitus, unspecified in pregnancy, controlled by diet. This question tests your ability to code obstetric conditions, specifically gestational diabetes, to the highest level of specificity. The keywords 30-week pregnant, gestational diabetes, and controlled by diet are all essential for selecting the correct code. ICD-10-CM provides specific codes within the 024 series to capture the type of diabetes in pregnancy, its control method, and the trimester if known. It's crucial to use these precise codes rather than a general diabetes code like E11-9 or a less specific gestational diabetes code. For example, if a pregnant patient has gestational diabetes controlled by insulin, a different specific 024 code would be used. Always ensure you capture all documented details, such as control status and trimester, when coding conditions related to pregnancy. Question 20. A healthy 55-year-old male presents for a routine colon cancer screening. The colonoscopy findings were normal. How should the screening encounter be coded? I. Z12-11, encounter for screening for malignant neoplasm of colon. B. Z11-1, encounter for screening for infectious disease. C. Z0000, encounter for general adult medical examination without abnormal findings. D. K63-5, polyp of colon. Answer I. Z12-11, encounter for screening for malignant neoplasm of colon. This question focuses on the correct use of screening codes in ICD-10-CM. The keywords routine colon cancer screening and healthy are critical, indicating that the patient does not have symptoms and the purpose of the visit is strictly preventive screening. Screening codes Z11, Z13 are used when the main reason for the encounter is to screen for a specific disease or condition. While Z0000 is for a general physical, a specific screening code takes precedence when a particular screening is performed. For example, a woman undergoing a routine mammogram for breast cancer screening would be coded with Z12-31. Always select the most specific screening Z code when preventive screening is the primary purpose of the encounter. Question 21. A patient presents with chronic, intractable low back pain. How should this be coded? I. M54-5, low back pain. B. G89-21, chronic intractable pain, malignant. C. G89-29, chronic intractable pain, other. D. R52-1, chronic pain. Answer C. G89-29, chronic intractable pain, other. This question tests the specific guidelines for coding pain, particularly when it's documented as chronic and intractable. The keywords chronic intractable low back pain are key. When a patient presents with chronic pain that is documented as intractable, meaning severe and difficult to manage, and there is no indication of malignancy, code G89-29 is appropriate. A code for the specific site of the pain, such as M54-5 for low back pain, would then be coded secondarily to provide further detail. R52-1 is a more general code for chronic pain, and G89-21 is for chronic intractable malignant pain. For instance, if a patient has chronic intractable neuropathic pain, G89-29 would be used, along with a code for the type of neuropathy. Always use the most specific pain code available, especially when intractable is documented, and remember to add a code for the pain's location. Question 22. A patient is admitted to a nursing home with a stage 3 pressure ulcer on their sacrum. This is the first admission for this ulcer. How should this be coded? I. L89-153, pressure ulcer of sacral region, stage 3. B. L89-150, pressure ulcer of sacral region, unspecified stage. C. L89-159, pressure ulcer of sacral region, unspecified severity. D. L89-151, pressure ulcer of sacral region, stage 1. Answer I. L89-153, pressure ulcer of sacral region, stage 3. This question assesses your knowledge of coding pressure ulcers and their staging. The crucial keywords are stage 3 pressure ulcer and sacrum, which demand a highly specific code. ICD-10-CM has distinct codes for pressure ulcers based on their anatomical location and the documented stage, from stage 1 through unstageable. It's essential to select the code that precisely matches the documented location and stage. Using an unspecified stage code, L89-150 or L89-159, would be incorrect when a specific stage is known. For example, a stage 2 pressure ulcer on the right heel would have its own specific code, L89-612. Always code pressure ulcers to the highest level of specificity regarding both location and stage, as this information is clinically significant. Question 23. A patient with a history of seizures is admitted to the emergency department experiencing a seizure due to deliberately taking less than the prescribed amount of their anti-epileptic medication. How should this be coded? I. G40-909, epilepsy unspecified, not intractable, without status epilepticus. B. T42-0x6A, underdosing of hydantoin derivatives, initial encounter. C. T42-0x1A, poisoning by hydantoin derivatives, accidental, unintentional, initial encounter. D. G40-909, T42-0x6A. Answer D. G40-909, T42-0x6A. This question tests the coding guidelines for underdosing and sequencing of related conditions. The keyword seizure due to deliberately taking less than the prescribed amount of their anti-epileptic medication are critical, identifying the underdosing as the cause of the seizure. In such cases, the condition resulting from the underdosing, the seizure, G40-909, is coded first, followed by the specific underdosing code, T42-0x6A, assuming hydantoin derivatives are the drug class for the anti-epilepticy. Underdosing is a distinct concept from adverse effects or poisoning. For example, if a diabetic patient experiences hyperglycemia because they purposefully took too little insulin, the hyperglycemia would be coded first, followed by the underdosing code for insulin. Always code the manifestation or condition first, then the underdosing code as a secondary diagnosis to explain the cause. Question 24. A patient presents with alcoholic cirrhosis with ascites. How should this be coded? I. K70-30, alcoholic cirrhosis of liver without ascites. B. K70-31, alcoholic cirrhosis of liver with ascites. C. K74-60, unspecified cirrhosis of liver without ascites. D. K70-30 are 18-8, other ascites. Answer B. K70-31, alcoholic cirrhosis of liver with ascites. This question assesses the use of combination codes for conditions with specific manifestations. The keywords alcoholic cirrhosis and with ascites are crucial because ICD-10-CM provides a single code that fully captures both the underlying condition, alcoholic cirrhosis, and its documented manifestation, ascites. It is always preferred to use a combination code when available, rather than coding the conditions separately. This approach ensures accuracy and avoids implying that the ascites is unrelated to the cirrhosis. For example, instead of coding diabetic ulcer as separate codes for diabetes and ulcer, a single combination code for diabetic ulcer would be used. Always check for combination codes that encompass both the disease and its associated manifestations for more precise coding. Question 25. A patient returns for a routine checkup after completing all chemotherapy and radiation therapy for lung cancer 6 months ago. The physician documents no evidence of recurrence. How should this be coded? I. C3490, malignant neoplasm of unspecified part of unspecified bronchus or lung. B. Z08, encounter for follow-up examination after completed treatment for malignant neoplasm. C. Z85-118, personal history of other malignant neoplasm of bronchus and lung. D. Z09, encounter for follow-up examination after completed treatment for conditions other than malignant neoplasm. Answer B. Z08, encounter for follow-up examination after completed treatment for malignant neoplasm. This question tests the distinction between an encounter for follow-up after cancer treatment and a personal history of cancer. The keywords returns for a routine checkup after completing all chemotherapy and radiation therapy, and no evidence of recurrence signify that the patient is still in an active surveillance phase following cancer treatment. Z08 is specifically used when the purpose of the encounter is to monitor for recurrence of a previously treated malignancy. A personal history code, Z85X, would be used if the cancer was entirely in the past and no longer required active surveillance. For example, a patient seen annually to check for breast cancer recurrence after a mastectomy would be coded with Z08. Always select Z08 when the patient's visit is for follow-up surveillance after cancer treatment, indicating an ongoing need for monitoring. Question 26. A patient is diagnosed with bilateral moderate primary open-angle glaucoma. How should this be coded? I. H40-111, primary open-angle glaucoma, moderate stage, right eye. B. H40-112, primary open-angle glaucoma, moderate stage, left eye. C. H40-113, primary open-angle glaucoma, moderate stage, bilateral. D. H40-119, primary open-angle glaucoma, moderate stage, unspecified eye. Answer C. H40-113, primary open-angle glaucoma, moderate stage, bilateral. This question tests your ability to code bilateral conditions accurately in ICD-10-CM. The keyword bilateral is crucial, as many codes provide a specific option for conditions affecting both sides of the body. When a condition affects both the right and left sides, and the documentation confirms this, the specific bilateral code should be used, rather than coding each side separately or using an unspecified code. This ensures the most precise representation of the patient's condition. For example, if a patient has bilateral cataracts, a single bilateral code, e.g. H25013, would be preferred over coding the right and left eyes individually. Always look for a specific bilateral code when the condition is documented as affecting both sides. Question 27. A patient is admitted with septic shock due to an E. coli urinary tract infection, UTI. How should the principal diagnosis be sequenced? I. R65-21, severe sepsis with septic shock, A41-51, sepsis due to Escherichia coli E. coli, and 39-0, urinary tract infection, site not specified. B. A 41-51, sepsis due to Escherichia coli E. coli, R65-21, severe sepsis with septic shock, and 39-0, urinary tract infection, site not specified. C. N39-0, urinary tract infection, site not specified. A41-51, sepsis due to Escherichia coli E. coli, R65-21, severe sepsis with septic shock. D. R65-21, severe sepsis with septic shock. Answer I. R65-21, severe sepsis with septic shock, A41-51, sepsis due to Escherichia coli E. coli, and 39-0, urinary tract infection, site not specified. This question tests the complex sequencing guidelines for sepsis, severe sepsis, and septic shock. The keywords admitted with septic shock are paramount, indicating that septic shock is the most severe and life-threatening condition. According to ICD-10-CM guidelines, when a patient is admitted with severe sepsis or septic shock, the code for severe sepsis with or without shock, R65-20 or R65-21, is always sequenced first. This is followed by the code for the underlying systemic infection, e.g. A4151 for E. coli sepsis, and then the code for the localized infection, and 390 for the UTI. For example, if a patient has severe sepsis from pneumonia, R6520 would be primary, then the sepsis, then the pneumonia. Always prioritize the severe sepsis/septic shock code as the principal diagnosis in such scenarios. Question 28. A female patient with a strong family history of ovarian cancer, mother and sister, decides to undergo a prophylactic bilateral oophorectomy. How should this encounter be coded? I. Z4009. Encounter for other prophylactic surgery. B. Z8041. Family history of malignant neoplasm of ovary. C. C56-9. Malignant neoplasm of unspecified ovary. D. Z4001. Encounter for prophylactic removal of breast. Answer I. Z4009. Encounter for other prophylactic surgery. This question tests the use of prophylactic surgery codes from the Z chapter. The keywords prophylactic bilateral oophorectomy and strong family history indicate that the surgery is performed to prevent a potential future disease, not to treat an existing one. In such cases, AZ code for prophylactic organ removal or other prophylactic surgery is assigned as the principal diagnosis. Z8041 family history would be a secondary code to explain the medical necessity for the prophylactic surgery. For example, a patient undergoing a prophylactic mastectomy due to genetic predisposition to breast cancer would be coded with Z4001. Always use a prophylactic surgery code as the principal diagnosis when the procedure is performed solely for preventive reasons. Question 29. A patient is seen for follow-up after receiving a cardiac pacemaker 3 months ago. The pacemaker is functioning well. How should the pacemaker status be coded? I. Z95-0, presence of cardiac pacemaker. B. Z45-018, encounter for adjustment and management of other cardiac device. C. T82-110A, mechanical complication of cardiac pacemaker electrode, initial encounter. D. I-49 for other and unspecified cardiac arrhythmias. Answer I. Z95-0, presence of cardiac pacemaker. This question tests your understanding of status codes in ICD-10-CM. The keywords after receiving a cardiac pacemaker and pacemaker is functioning well indicate that the patient has an implanted device that is not causing any current issues but is relevant to their overall health status. Status codes Z90, Z99 are used to indicate that a patient has a residual condition or a permanent state, like the presence of a medical device, that may affect the course of treatment but is not a current illness or injury. Z45-018 would be used if the pacemaker required adjustment, and T82-110A if there was a complication. For example, a patient with a colostomy would be coded with Z93-3, colostomy status. Always use a status code to capture the presence of an implanted device or other permanent condition that is not currently problematic but is important for the patient's medical history. Question 30. A patient is admitted to the hospital with confirmed COVID-19 pneumonia. How should this be coded? I. J12-89 other viral pneumonia. B. B34-2 coronavirus infection unspecified. C. U071 COVID-19 J12-89 other viral pneumonia. D. J12-89 other viral pneumonia U071 COVID-19. Answer C. U071 COVID-19 J12-89 other viral pneumonia. This question tests the specific ICD-10-CM coding guidelines for COVID-19. The keywords confirmed COVID-19 and pneumonia are crucial. According to official guidelines, code U071 COVID-19 is designated as the principal diagnosis when the infection is confirmed and is the reason for the encounter, regardless of the manifestations. The manifestations, such as pneumonia, J12-89, are then coded as secondary diagnoses. This sequencing rule ensures that the primary reason for the patient's encounter is accurately reflected. For instance, if a patient has confirmed COVID-19 with acute respiratory distress syndrome, U071 would be primary, followed by J80 ARDS. Always sequence U071 as the principal diagnosis for confirmed COVID-19 cases, followed by codes for any associated manifestations.